Hello, this is Kim Jong-il. Today, on our third lecture on the double arch wires, we will focus on case studies. This is a Class 2 high-angle, non-extraction case. This 13-year-old female patient's CC were gummy smile and deep bite. Her front profile is not bad, and we can observe the retruded mandible from the side profile. Let's look at the intraoral photos. There is no severe observable crowding in the maxillary and mandibular anterior regions. Crowns have been formed in the maxillary and mandibular third molars. The first and second premolars of the maxillary lateral tooth group are inclined palatally, and the mandibular teeth are lingually inclined accordingly. Let's look at a picture from the front. From this photo, there is no asymmetry in the maxilla and mandible. We can observe asymmetry at the chin point. The profile from the front is not too bad. This patient shows signs of deep bite. We must look at the canine key. Looking at the canine key, both left and right sides display Class 1 canine relationships. In particular, we can see that the crowns of the maxillary first and second premolars are palatally inclined. We just evaluated the patient's relationship between the lower lip and maxillary incisors. We used a dental probe to see where the lower lip was located. It is at the gingival area of the maxillary incisors. The ideal lower lip position is at the incisal third. Can we intrude the maxillary incisors to the ideal position? This patient's U1 to lip line is 10 millimeters long. We would need a lot of intrusion. Let's look at this patient's ODI, APDI, and CF. The AB to mandibular plane is 68 degrees. Because the ANS is located downward, the palatal plane has a positive value. Therefore, the ODI is 69.5. Since point A is located anteriorly, the AB plane angle has a negative value. Therefore, the APDI is 76 ODI, 69.5. APDI 76, CF 145.5. So this patient has a Class 2 high angle. The ODI and APDI may change, but the CF will not change. This patient has a FMA of 37. Is this a case of skeletal deep bite or dental deep bite? It's a dental deep bite. Therefore, the bite easily opened. The U1 to lip line is 10 millimeters. The UOP is 23 degrees and POP 26 degrees. The U1 to FH is 92 and IIA 131 degrees. We can notice that the maxillary incisors are heavily extruded and inclined palatally. Let's look at this patient's problem list. The profile is not bad. A possible solution would be non-extraction treatment. Even for cases of deep bite, non-extraction treatment is preferred if possible. The maxillary incisors are over-erupted. Therefore, we should perform non-extraction treatment if possible and intrude the maxillary incisors. Because of the steep UOP and POP, it is necessary to upright the posterior region and adjust the occlusal plane. There is linguoversion at the maxillary incisor with U1 to FH of 92 and IIA of 141 degrees. We should perform treatment without extraction if possible. Most orthodontists would agree. Let me first explain the facial asymmetry of this patient. There's a limit to 7 millimeters intrusion. To perform 7 millimeters intrusion, surgery may be required. However, the patient refuses surgery because the facial profile is not bad. Then our second option would be orthodontic treatment. Because the crown length of the maxillary incisors is short, crown lengthening is required. Retention should also be considered during the diagnostic procedures. Deep bite cases such as this often recur. It is true that cases of dental deep bite, such as this patient, tend to recur less than the skeletal deep bite. But there are still possibilities of recurrence with extrusion of the maxillary incisors. We must use a removable retainer with an anterior bite plate with an incisal cap, and possibly extract the third molar in the future if deemed necessary after observation. In such cases, anyone will decide on non-extraction. There will be strategic leveling, use of intrusion arch, and the anterior bite plate. Because this is a case of dental deep bite, the bite will open soon if we use the anterior bite plate. We then engage Mio on the maxilla and mandible to complete the treatment. The device was first attached to the maxilla. The initial arch wire is 0.014 NET. In order to avoid crowding in the anterior mandible, an anterior bite plate was attached to the maxilla, and strategic leveling was done on the mandible. An open coil spring was used around tooth curve 41. The anterior bite plate was delivered in April. We can notice that the bite has been opened in only 2 months. Why? Because this is a case of dental deep bite. If this patient had a combination factor of over 160, the bite wouldn't have opened this easily. Because this patient's case is a high angle type, we can see the bite opens with the mandible when the bite plate is attached. After leveling, gingivectomy was performed on the maxillary anterior region first, and the Mio was engaged afterwards. Mio is necessary to coincide the midline and establish the occlusion. We can see the crown length had increased before gingivectomy was performed. If the Mio was engaged when the maxilla was in this state, food would more easily be stuck between the teeth. The maxillary incisors were intruded by using the double arch wire in the maxillary anterior region. The Mio was engaged afterwards. If we look at the photo after the MEAW was engaged, we can see that the mandibular midline is slightly deviated towards the left. Because the deviation is towards the left, we can use short class 3 elastics on the right and short class 2 elastics on the left. On details of applying elastics, refer to the finishing part. The important thing to note here is checking the midline and the left and right canine relationships. This will allow us to easily remove the device. We can now observe a desirable class 1 canine relationship and the bite opened. If we compare the panorama before and after treatment, we can see that the mesially angulated mandibular molars have been uprighted. If we compare the PA before and after treatment, although there was no significant difference between the left and right before treatment anyway, we can see that the patient definitely has a more confident smile after treatment. This is the lateral ceph before and after the treatment. As we can see, the bite has been opened, but not by much. We can see that the mandible, maxilla, incisors, and molars have all slightly moved. The treatment took 1 year and 4 months to complete. An important thing to note is that the combination factor never changes. We can see the U1 to lip line decrease from 10 mm to 7 mm through intrusion. I believe orthodontic intrusion can normally intrude by 3 mm, maximum 4 mm. We can see that the condition after orthodontic treatment has been well maintained after 25 months. These are the photos of maintenance before and after treatment. The arch shapes of the mandible and maxilla have changed. We can see that the normalization of the arch form pushed the mandible, which was originally located backward, forward. Let's review the entire process. The maxilla was leveled first, the mandible was leveled afterwards. The double arch wires were used to intrude the maxillary incisor. The crown was lengthened to prevent the maxillary anterior crown length from decreasing when we intrude the maxillary incisor. Mio was inserted in the mandible and maxilla. The midline and the lateral tooth occlusion was adjusted to complete the treatment. The treatment procedure for Mio orthodontics is strategic leveling first and finishing with Mio. If the maxillary incisors are extruded, we can perform strategic leveling using the double arch wires and finish using Mio. Thank you for watching.